Good morning, everyone. My name is Carol Danter, and I will be talking this morning to you about management of headaches in primary care. So we're going to start right off the bat with a case. This is a case near and dear to me, as it was one of the first patients that I saw after graduating from PA school 20 years ago. So, 34-year-old female presents to the ear, nose, and throat clinic with a chief complaint of headaches for 1 month. She also, she describes these headaches as dull, constant. She states these are the worst headaches she's ever had in her life. And she has sort of a hollow feeling in her ears. It feels sort of strange to her. She denies any exertional symptoms. What that means is that when she walks upstairs or she lifts something heavy, the headache does not get worse. She doesn't have any photophobia, so the light doesn't bother her, no nausea, and no phonophobia. So when there's loud noises, that doesn't bother her either. The headaches have been present, as stated at the top, for 1 month, and they're getting worse. Anything stick out to anybody? Anything seem out of the ordinary? Sherry?
Worst headache ever.
Very good. That is what we call an alarm symptom. And that's something that should get your attention. Somebody comes in and they say, this is the worst headache of my life. Right away, your ears should perk up and you know that that's an important piece of information. So let's go on. She's never had headaches before. And her primary care had diagnosed her with sinusitis. And she's just finished a course of Augmentin and Claritin. She had no response to this treatment. And on physical exam, everything's normal, so no neurologic signs or symptoms. And general inspection reveals a woman in no acute distress, and she looks healthy. She's a vibrant-looking young woman. And because I was in the ear, nose, and throat clinic, of course, I tested her hearing because she had this hollow feeling in her ears, and the hearing test was normal. So, ordered a CT scan, and she was diagnosed with a cerebral artery thrombus, and her PCP took over care again. She was admitted to the hospital, started on heparin with a bridging to Coumadin, and the next morning I came to work, and there was this lovely note on my desk that our secretary had taken, and it said, "Thank you for saving my life." So, that was sort of a banner day in working as a PA. You don't always have those notes on your desk, nor do you always, have a find that's so exciting to know that you've really made a difference in somebody's life. But it is something that you, as PAs, when you're out there working, will definitely have the chance to have experiences like that. So, I started off with that case just to show you that the diagnosis of headache could be something very benign, like a tension headache, to something that could be life-threatening. And we will go into those conditions as we go on. So what are we going to do today? First thing we're going to do is talk about differential diagnosis. Then we're going to learn the parts of the history that you need to take when evaluating someone with a chief complaint of headache. What physical exam findings are you going to test for and look for? The alarm signs in both physical and history that would tell you that this could potentially be a serious cause of a headache. We're going to talk about some common headache disorders and how you treat them, and disorders not to miss. A few facts. The World Health Organization ranks severe migraine as one of the most debilitating chronic conditions that people can have. 71% of women and 50% of men have tension-type headaches, so this is not an uncommon problem that you will be dealing with. It's very, very common. 13% of women and 6% of men experience migraines, and the direct and indirect costs are in the billions, 17 billion for the last information that I can find. And most people self-treat. People are taking, Advil over the counter, aspirin, Tylenol, whatever they can get their hands on. The pathophysiology of headaches, they are not very well understood. Migraine and tension headaches have some similar features, and there's some theories that they are a continuum of the same type of disorder. And until the 1930s, we thought that there was increased blood flow, and that was the primary reason for headache. We now know that there are many neurochemicals involved, and that the blood vessels and the pain system in the brain is sort of over sensitized, and that it's a pain syndrome. We do know that the pathways affecting vasodilation and constriction and pain are affected by these neurochemicals. Recently, we have discovered some genes, so that's a good thing because it may lead to some more specific treatments in the future, so that is on the horizon. And so I want to start by talking about the common primary causes of headache. So we are going to review tension headaches, migraine headaches, and cluster headaches. And I'm going to stop there.